Welcome. So tonight with us, hi, I'm Caitlin Esposito. I'm with the Bobby Jones Chiari and Sphingomyelia Foundation. It's really good to see you, Dr. Strahle. I haven't seen you, I think, in like 2 years now. We would have seen you in April, but
Yeah,
unfortunately.
yeah.
So Dr. Strahle is a pediatric neurosurgeon at St. Louis Children's Hospital of St. Louis? St. Louis Children's Hospital.
Yeah, St. Louis
Yeah.
Children's Hospital.
Okay, and she's been a member of our medical advisory board, the C board, for the past 3 years, right? I think.
I
Yeah.
think so.
But what I usually like to do is make sure whoever's speaking, kind of like starts by kind of saying what got them into studying Chiari and what drew you to this group and why do you think, just you get it.
Yeah. So, a question for me.
Yes, yes.
Yeah. Okay. So, I I'm a practicing pediatric neurosurgeon, and Chiari is a large part of my practice. I actually began studying Chiari when I was a resident, and the reason why is that, as many of you may know, the name and term and diagnosis of Chiari malformation is actually quite common. And so I was seeing a lot of patients in clinic with a diagnosis of Chiari malformation. And so my mentor, Cormac Marr, he and I started asking some questions about, how common is this? Is this something that is always associated with symptoms? Is it something that you can have and not have associated symptoms? So that was really the beginning of my introduction into Chiari. And so it's interesting, when we first started, the way that we talked about Chiari malformation is different. So this was over just about 10 years ago. We've learned a lot in the last 10 years. And even terms such as tonsillar herniation, which was a sort of an old term which used to describe what happens with a Chiari malformation. We're now using terms like tonsil position, as we know that just like height, weight, head circumference, the position of the cerebellar tonsils does follow a bell curve, just like those other measurements. And so just because you have a tonsil position that is lower than the 5 millimeter line that was defined back in 1985, it doesn't necessarily mean that your specific tonsil position is associated with particular symptoms. So that was sort of the beginning of my introduction into Chiari. And then now some of my more recent research focuses on the interplay between Chiari and syrinx and then scoliosis. And so we're still working to figure out, how do we identify those patients who will ultimately need surgery and will benefit from surgery versus those who may have symptoms such as headache, which is very common, but may not necessarily be related to the Chiari malformation.
All right, my video got a little wonky there, so I'm sorry if I looked weird. That's great. And I guess we can kind of start then with some basic questions about Chiari. Let's see. I think I want to start with, since you kind of talked about it a little bit, how the tonsil position can change over time. There was one question about if a child has quote unquote a significant Chiari malformation, so it's maybe 5 millimeters or more, how likely is that patient to develop a syrinx or new or worsening symptoms? Or is it something that maybe over time the Chiari will get better? And it's in theory, if that patient doesn't have symptoms now. Did that make sense?
So yes, very good question. So as you probably know, we looked at what you call the natural history of Chiari. So let's say you're diagnosed with Chiari without any intervention, what's going to happen over time? And so at initial presentation, if your clinical picture is such that your treating physician, and just so I understand, this is mostly, we have patients in this group or some physicians?
Yes. Or this is mostly going to be patients.
Okay, great. Okay. So if your treating physician feels that at the time of your initial diagnosis that you do not need surgery, it's very unlikely that you will go on to need surgery for the most part. So if the initial decision is for conservative management, meaning, you know, close follow-up, it's unlikely that you'll need surgery in the future. There are those patients where we have that initial visit and we're still sort of under suspicion, so there's that middle ground. But this is for the patients where, you know, at initial diagnosis, there's not a thought that you're going to need surgery. It's unlikely that you would then need surgery later on. And then you mentioned, I think, something about, you know, tonsil position itself. For the most part, tonsil position within an individual remains about the same. You do have some tonsils that the tonsil position becomes more cranial, meaning if we're all talking about the measurements that I think we're probably all familiar with in this group, the reference point is the foramen magnum or the skull base, and the number of millimeters. So 5 millimeters was sort of an arbitrary cut point that was, again, defined back in 1985, which is still used today for the most part. Although our neuroradiologists are now using a term Chiari type configuration of the tonsils, or just tonsil position, and not necessarily assigning that Chiari malformation diagnosis to a tonsil position specifically, because that doesn't tell the whole story. For the most part, your tonsil position remains the same. If you look at a big population of people, so kids, individuals in their 20s, 30s, 40s, and on up, if you look at those, not necessarily in the same patient, because we don't have MRI with 90-year follow-up. If you look at a population of patients in general, after about your 20s, the tonsil position continues to become more cranial, meaning that number would become less.
Mm-hmm. We have a lot of really good questions coming up. So I just want to ask this one because it's sort of related. What symptoms warrant surgery? And are those symptoms going to be different in an infant or a school-age child or an adult?
Mm-hmm. So that is the main question that I think us as myself as a pediatric neurosurgeon and any treating physician is really, you know, trying to understand is who, you know, as a pediatric neurosurgeon, I have 3 kids of my own. Anytime I recommend a procedure, I want to make with as much certainty as I can that I want to determine with as much certainty as I can that the procedure will treat whatever symptoms the patient is presenting with. So if it's unclear or there's a question, I'm very conservative in my management. So as many of you may or may not know, anytime there's a procedure, there are potential risk involved, and we really want to make sure we're not putting patients through surgeries that might not actually help their symptoms. So if I come back to your question, you were asking sort of what symptoms would warrant surgery. So right. The one that most neurosurgeons would be in agreement upon is a very large expansile syrinx. So a syrinx, as most of you know, is a fluid collection within the spinal cord, and it's associated with Chiari malformation about 20% of the time. So in those patients with a syrinx, particularly a syrinx that's very large and that actually expands the spinal cord, most physicians would recommend surgery. Interestingly, for syrinxes, those patients don't always present with headaches. They more often present with scoliosis, which is a curvature of the spine. And we know from studying that relationship that the scoliosis is associated with the syrinx itself. So it's unusual to have a direct link between a Chiari and scoliosis in the absence of a syrinx. So things like Chiari associated syringomyelia, plus, especially in the setting of scoliosis, would be a strong indication for surgery. In terms of symptoms outside of imaging findings like a syrinx or scoliosis, the most common presentation would be, and I'm sure many of you may know, occipital type headaches that are worse with activity or exertion, like coughing or sneezing. That's sort of the classic, you know, Chiari presentation. As many of you may know, headaches are super common, and there's all sorts of different headaches, and so then it gets a little bit difficult to sort out beyond those classic headaches. Then it becomes more of a discussion, and we typically follow patients to understand who may best benefit from surgery. But that question related to, you know, what specific headache type may or may not be associated with Chiari, I think is something that we're still learning more about.
Yeah. Are those symptoms going to be different in an infant or say an adult? Yeah.
Sorry. Thank you for reminding me of that portion of the question.
Right.
So, you know, an infant that is 1, 2, or 3 years old may not be able to communicate specifically their headache location. They may grab at their ear or grab at their neck. So it's a little bit more difficult to determine that. Young kids, particularly those under 3, may present with things like sleep apnea, so central sleep apnea, and swallowing difficulty. Those would be symptoms that might be more prominent in someone that's younger. The headache type specifically, with respect to age, I don't have an answer for you right now. There may be some research related to that, but it's not an area of my particular focus. But that is a good question about headaches associated with Chiari by age, and how you would, you know, further determine headache type and location in an infant.
Yeah. Does the syrinx, so if there's an associated syrinx, does it need to be in a certain section of the spine, or have you seen like syringomyelia that goes the entire cord?
Mm-hmm.
Are there sometimes syrinxes that are way down at the bottom? Is that kind of unusual?
Thank you for asking that. About 85 to 90% of syrinxes that we see with Chiari malformation begin in the cervical spine. So most of the syrinxes we see start in the cervical spine, and that sort of makes sense because it's closer to the site of pathology. You can see syrinxes with other things such as tethered cord, which is at the opposite end of the spinal cord. When you have a low-lying spinal cord, those syrinxes tend to be lower down. So there can be a case where you have a child with a Chiari malformation and a syrinx, and we may not necessarily attribute a direct link between those two, because syrinxes themselves are also, you know, they come in all shapes and sizes. So what I mentioned earlier was a big expansile syrinx. A small syrinx, or a dilation of the central canal of the spine, so something in 3, 4, 5 millimeter diameter, is, you know, may be seen for other reasons and may not necessarily be directly related to the Chiari. So there could be a scenario where you have someone with a Chiari and then a small thin syrinx in the lower thoracic spine, for instance, that I may say as a, you know, as their treating physician, and if, let's say, this was found sort of incidentally and there were no other symptoms, that type of syrinx would not necessarily be an indication for surgery.
Mm-hmm. So before I asked a question about scoliosis, because I know you did a lot of work on that, there's a question about aspiration and delayed milestones in infants and kids. Is that something that you see frequently with Chiari patients, or is it just
So that's a good question. We're continuing to understand more and more about the cerebellum, and so not with Chiari, but in other things like brain tumors, we're actually finding that the cerebellum has a lot of functions that we previously, you know, did not really know about, related to speech and other things. In general, and you'll probably, you know, if you asked 100 pediatric neurosurgeons, you might get a few different answers. What I tell my patients is I think in terms of delayed milestones related to things like speech or general milestones like general fine motor, I don't think are necessarily directly related to Chiari malformation. So what happens is when you have delayed milestones, those children are undergoing MRIs, you know, for that, and then the MRI may pick up a Chiari malformation. And so we have to be really careful about when we assign causality in that case. So aspirating is definitely a concern. I would sort of put aspiration separate from the delayed milestones. I would be concerned about swallowing difficulty, and then I would look in a little bit more clearly. But like I mentioned earlier, sort of central sleep apnea and swallowing difficulty, we do see more of a direct relationship there, meaning that when we do a decompression, those symptoms can improve in that way.
Yeah, actually, I don't know how much you know about this work, but there's some work being done at your institution, in fact, about the cerebellum and what we're learning about it. Is there anything you can speak to that a little bit? Just because I'm actually not even clear on it, so I'd love to hear.
So in relation to, so there's a lot of imaging at Washington University in St. Louis. We have a very, very strong human imaging program. So there's a lot of advanced MRI techniques that are done for research purposes. And then a lot of what we call functional imaging that's it's done without needing to do tasks during the MRI. So in children, we're able to understand more about actual active function in different networks of the brain. And there are ongoing studies related to Chiari and those networks that are ongoing that haven't, the conclusions of which have not yet been determined.
Yeah, and I'm going to interject here that this is research, not clinical radiology kind of stuff,
Correct.
Right? Right.
Correct. Well, those, yes. So there are some more advanced techniques that have been found to be helpful that are used at certain institutions in the clinical setting. But what I was just describing was more from a research perspective.
Right. Can you speak a little bit about some of the work you've done with the correlations between scoliosis and Chiari?
Mm-hmm.
What does it mean for outcomes in patients with both of those?
So in a patient that presents, with Chiari, syrinx, and scoliosis, so there's, I guess, two different scenarios. One would be Chiari and scoliosis and no syrinx. The other, Chiari, syrinx, and scoliosis. There are very few patients that we see that have scoliosis and Chiari without a syrinx. So I'll probably leave that sort of separate. That's a more, I think, individualized situation. And based on the research that we've done, I think it's unlikely, as I mentioned earlier, that there would be a direct connection between the Chiari and scoliosis. So scoliosis in and of itself as an isolated symptom in a patient with a Chiari and no syrinx would not necessarily be an indication for surgery by most. But again, I can't speak for everyone because that's a very, well, one, I'm speaking for myself, and there is, I know that there's been a lot of different, folks coming in, and so I'm sure you'll hear some variations because there are, practice variations and different, different thoughts on approaching Chiari. So in a patient with Chiari, syrinx, and scoliosis, the management strategy typically is for a decompression. The main question that is asked in that situation is what type of decompression. So I think most of the group probably knows. Should I review the sort of the types of decompression, or?
I think it'll help just briefly.
Mm-hmm. So in order to treat Chiari, we focus on restoring spinal fluid flow at the base of the head and upper neck, because that's really what's happening with the Chiari. If it's symptomatic, it's disturbing the spinal fluid flow in that area. So by decompressing that area, we're allowing for the spinal fluid to flow more freely. And when you have Chiari and a syrinx, the syrinx accumulates because the spinal fluid is not able to flow in its normal path, and it ends up accumulating in the spinal cord. When you have a lot of fluid in the spinal cord, you then are at risk for developing scoliosis. So of patients with greater than 50% of patients with syrinx and Chiari end up having scoliosis, depending on, it can be up to that high.
Mm-hmm.
So we definitely think about that. And so in someone that is growing, if they have scoliosis, let's say the individual is 8, 9, 10, 11 years old, there's a chance for that scoliosis to get worse. So most recommend treatment. The question is, for the decompression, there are two main types of decompressions, and I'm just sort of simplifying things a little bit, and just for the sake of discussing everything. One where we take the bone off, which is the small window of bone at the base of the skull, and then the back part of the first cervical vertebra. With that, we usually take down a ligament. So the dura is the name for the covering that holds all the spinal fluid in, and it surrounds the brain and spinal cord. There's a ligament over the dura that we typically take down when we only are taking off the bone and not opening the dura. We do take down a ligament, so there is some additional decompression. When we think that that's not going to be enough, the other procedure involves opening the dura and sewing in a patch. The reason there's so much discussion about this, you may ask, well, why not open up the dura and sew in a patch in everyone? It turns out that when we open up the dura and sew in a patch to make it bigger, you can have complications associated with that, like spinal fluid leak or a collection of fluid underneath the skin. Sometimes patients have irritation of the dura and they feel just a little crummy for a little while longer. So we're really careful in who we recommend that procedure to. When you think about someone that's growing in scoliosis and the time course over which the syrinx gets smaller, we know that in the bone-only decompression, it takes longer for the syrinx to decrease in size than it does with what we call the duroplasty. When we open up the dura, because you have more room, the syrinx decreases more quickly. So we presented this as an abstract at the Ped section meeting last year, and then it's currently under review, looking at the differences between those two surgery types in a patient with Chiari, syrinx, and scoliosis. So that information will sort of be forthcoming.
Okay. Well, that's good. I'm going to be looking for that. So do you, I guess to kind of really briefly touch on the decompression with or without that bone, do you generally do one or the other? And what are your thoughts on resection of tonsils?
Okay. So my decision, it's a very individualized approach. So there are some patients, and this is another study that we're doing, trying to look at the sort of the back part. Many of you may know there's some measurements that we use for the front part of the spine, like I don't know if the group's familiar with things like CXA and PBC2. Okay. So there hasn't been a lot on, there's been some research on looking at the volumes and different dimensions of the back part of the skull. But there's not a lot on looking at the angles at which the occipital bone sort of comes into the spine. So in some kids, especially younger patients, if you look at their MRI, it's clear that the bone itself is sort of pushing in. So in those kids, and in younger kids, their dura, the covering, can be very vascular. So I think my practice is to not open the dura unless I really need to in someone that's on the younger, that's younger, sort of under 2, 3, 4 years of age. But in some of those kids, when they present, let's say with Chiari, I see in my personal experience, a number of those kids actually have more of the way that the occipital bone it's more sort of horizontal like this rather than sort of straight up and down, and sort of it sticks into the area of the foramen magnum and causes additional compression. So those kids, I plan on doing a bone-only decompression because I think the compression is mostly bony in nature. There are some children who I look at the bone and it does not look like the bone is really causing much compression. And in those patients, I have a discussion with the family that I think it's likely that they may need a duroplasty, which is the sewing in the dura. I use ultrasound in the operating room to assess after I remove the bone and after I remove that ligament, whether or not we need to open the dura. So my approach is more of an individualized approach based on their anatomy. There's sort of an in-between where you can do dural splitting, where you sort of take the dura and relax it a little bit such that it stretches out a little bit. So that's one technique. And then related to the tonsils, my sort of philosophy, and this is my philosophy, I'm sure you'll get a lot of different answers from different pediatric neurosurgeons, is that while the position of the tonsils is lower down than some, and if I'm doing a decompression, it's clearly the patient's having symptoms. The tonsil is a normal tissue and part of the brain, and as I mentioned earlier, we don't yet fully understand all the functions of the cerebellum. My practice is not to take the tonsils. I leave the tissue in place because there may be functions of the tonsils that we don't yet know, and my practice is to leave them.
Yeah. Kind of to the dural splitting technique that you just talked about. So I know there can be increased risk of complications with duroplasty. Is that similar to dural splitting, or is that less likely?
It's less likely because you're not really opening the dura. You're just sort of taking. So the dura in the over the head portion has 2 layers, and there is vascularity in that dura. So it's difficult to split the dura sort of in that upper region. But right at the base of the skull, like I talked about that band. So once you take that band down, the dura itself can also seem tight. And once the dura transitions to the upper cervical spine, it's really one layer, and it's so a little bit safer to take that and just take that very, very superficial layer, and it sort of allows it to relax a little bit. So,
so it's closer to bone
only. What?
It's closer to bone only than to dura.
Correct.
Okay. Correct. There was a question. So you had brought up the CXA. So what correlation do you see between like hindbrain malformations and connective tissue disorders? And is CXA the only way you measure that, or are there other things that you can do either in the clinic, or if it's just research based now, what would you say to that?
So the relationship between
connective tissue disorders and like kind of like instability and what that means, I guess, for the surgical practice.
So yeah, the CXA is sort of a measurement of how the angle of the skull base. So we do see some kids with Chiari that have a more flat skull base. I don't know if anyone's heard of the term platyphagia. It's sort of more of an acute angle. I don't use that necessarily in a specific relationship to connective tissue disorders. If I'm concerned about a connective tissue disorder, of course, I have that, we evaluate for that first. If I'm concerned about hypermobility relating to the upper cervical spine, I usually use dynamic films such as flexion extension cervical x-rays to look for any abnormal motion. So that's more of how I would evaluate stability in that case. But there can be relationships with that.
Your response kind of just made me come up with another question I just kind of want to piggyback off of. Can you be hypermobile in other parts of your body and it doesn't impact your cervical spine at all? Or greatly?
Yes, so there's the idea of hypermobility is, I think, has garnered a lot of interest more recently, and we do a lot of screening in our patients for, there's different scores that you can do. The diagnosis, for instance, of Ehlers-Danlos is there's different types, and there's it's a little bit more broad, and so the diagnostic criteria aren't, it's not. There are a lot of different types of patients that can be given that diagnosis with varying degrees of hypermobility. So the patients I see that have a more severe type of it can have hypermobility everywhere, but in other cases, hypermobility can be restricted to particular joints. So the easiest way to, it's not necessarily the best, the easiest way to evaluate for abnormal motion is with those flexion extension x-rays. But as you know, the neck moves in all different ways. It's just difficult to get dynamic x-rays, for instance, with lateral side bending. And so if we're really concerned about a patient, and this sort of gets outside of Chiari itself necessarily, because I think it would be unusual to see a Chiari patient with severe instability of the cervical spine, we can get additional dynamic imaging with CT or MR in different different sort of positions. But for most pediatric neurosurgeons, our sort of first step in evaluation of joint instability at the upper cervical spine would be these flexion extension x-rays, but they are limited. They can be limited, particularly with the occipital, the joint between the occiput and C1 too.
This is an interesting question. I never thought about it. Do you see patients, I assume in the setting of Chiari, with the opposite problem of like hypermobility? So maybe they have like really tight or like tough joints that don't exactly, they're kind of creaky, I guess.
Yeah. I guess in terms of stiffness, I guess not necessarily, but you know, we see patients with a wide range of symptoms, so it's not impossible. But there's, I think, less of that association than you know, that the interest in looking at patients with low tonsil position and these hypermobility disorders. I think partially just because there's a lot more attention into the hypermobility disorders, because we really don't, especially at Eros-Danlos, we don't fully understand it.
Yeah.
So there's a lot of focus on it, and a lot of patients have pain from hypermobile joints that we don't have great answers to. So I think that's why there's a little bit more attention in that area.
Yeah, absolutely. This is a good question that came in earlier. What's the first thing that a neurologist or a neurosurgeon would recommend for a newly diagnosed person with Chiari, or child or adult?
So, so I see Chiari is probably the most common diagnosis that I see in clinic. Multiple patients a day in clinic with a diagnosis of Chiari, a new diagnosis of Chiari. And they're all a little bit different. So as I mentioned earlier, there's, I think there's a trend towards the language in the radiology reports being a little less specific as to a Chiari malformation, but still we see a lot of radiology reports that say Chiari malformation, and everyone gets grouped into one big bin with Chiari malformation. That's really not the case. It's really a wide range of patients with you know, different tonsil positions and different presentations. So there are a number of patients that come to clinic that have a quote unquote Chiari malformation that I look at the imaging. They have nice rounded tonsils. They may stick down, you know, a few millimeters below the skull base. There doesn't appear to be any compression. They have no symptoms. And let's say they had an MRI because they fell and hit their head, had a CT scan, there was a question of a Chiari, and then they get an MRI, or have an MRI for, I don't know, any seizures is a common reason for an MRI. So if there really isn't a concern for symptoms, there are select patients where I will say, I don't think we need any further evaluation, and you know, we can follow up. Usually I'll do one additional follow-up in about a year, just to make sure things are going okay. If a patient is younger, I'm maybe more likely to follow them in that particular scenario than I would if someone, you know, presented that was a little bit older. For a patient where they have a Chiari malformation where the tonsils are, you know, a little bit lower down, it's not a borderline case in terms of the position of the tonsils, and the tonsils may appear to be more peg-shaped, not as rounded, there's not as much room there. I usually recommend getting a spine MRI to evaluate for syrinx. In the past, or I should say, a number of individuals will really make sure to view the end of the spine to rule out something like a tethered cord. The direct link between Chiari and tethered cord, I think, is still debated, but it is something in practice that, you know, with that spine MRI, that's also something that's being looked at there. And then depending on their particular symptoms, we would then determine monitoring from there. If I'm not initially recommending any intervention, I usually follow up at a year, and if things are okay, then it can either be as needed or clinical follow-up.
Okay. I don't want to ask this yet, so I'm going to just do something else really quick. What's the best thing to do or not to do when a Chiari headache comes on? So like, how can you kind of make sure it gets, say you haven't had surgery or you're monitoring, but the headaches, you can live with them. So how do you live with them? What do you avoid, or what do you try to do?
So for so I guess that's a little bit of a difficult question to answer. So headaches are very common, and so I guess it depends on if we truly think the headaches the patient is having are directly related to the Chiari. So if you're having a headache that is thought to be related to the Chiari, the what we think is probably happening is that the spinal fluid, so when you have exertion or there's a transient increase in pressure in the head intracranially, the spinal fluid is not able to sort of escape out, and so there's transient elevations in intracranial pressure. If that were the case, then I would, and it's activity provoked, then I would cease doing whatever activity that is. So just resting, taking some deep breaths, trying to relax, sitting down, and letting them pass, and then avoiding the activity that provoked the headaches. Mm-hmm. It gets a little bit difficult to make a recommendation beyond that when there are a lot more types of headaches that may not clearly be migraines, or there's no clear reason for the headaches, and a patient has a Chiari. There's sort of these in-between headaches. And so the recommendation, let's say the headaches may be associated with sensitivity to light or noise, or have some other characteristics that, may not sort of fit the typical Chiari headache. Not all headaches related to Chiari have to, fit the description. But there are some cases where we're unable to say for sure, is this headache related to the Chiari, or is it related to something else? And so, given that headaches can be so diverse in their presentations, it's difficult for me to say a particular strategy for a Chiari headache outside of the scenario that I mentioned at the beginning.
Do you so regarding like some symptoms, so obviously headache, maybe other types of pain or anything like that, are there any kind of holistic, I guess is the kind of word I'm looking for, are there some different things that patients can maybe try? So like chiropractic, maybe massage, yoga, maybe even acupuncture. What would you say about any of those?
So so for chiropractic manipulation, what I tell my patients is that there are case reports, and I have seen patients who've had strokes from high velocity neck manipulation. So, and I don't think chiropractors are maybe doing as many high velocity neck manipulations, but as many of you may know, there are two very important arteries that run in the cervical spine called the vertebral arteries. And when you crack your neck forcefully, particularly when someone else is doing it, those arteries are at risk for being injured. When those arteries get injured, they can cause small blood clots within the artery that can then shoot off and potentially cause a stroke. So I encourage my patients to, let's say they have headaches that I'm not certain are directly related to the Chiari, but they're having difficulty in managing the headaches. We usually send our patients to our neurology colleagues for their help in management of the headaches. But beyond that, as you know, there are many, many modalities that we are finding that are very, very helpful for headaches and back pain and neck pain. So if you see a chiropractor, I would just avoid the high velocity neck manipulations, just because of that artery. Beyond that, I encourage any other modalities, such as acupuncture has been found to be very helpful for different headache types and back pain. Similarly, yoga. Sometimes if we're concerned about hypermobility, sometimes yoga can exacerbate some people's symptoms because there's a lot of stretching involved. Pilates, sometimes headaches are caused by just global core strength too. So thinking outside the box, let's say you have headaches and you're having trouble trying to figure out why you're having headaches. Pilates is a great sort of overall global way to just sort of strengthen everything. And these aren't, this isn't necessarily, there aren't large scale studies that have investigated these particular things. People have looked at pain management post-operatively with some of these strategies and found that that's helpful. But these suggestions that I'm mentioning are more just in the spirit of, I think that there are safe and reasonable options to try and help headaches. But I am a big fan of acupuncture. Some people say that it works really well. And so, that and other modalities I think are helpful, with the exception of the high velocity neck manipulations.
That was a great answer. This is an interesting question. How much sensitivity to light or sound, different stuff like different sensory types of things, how much of that could be resulted from compression on the cranial nerves?
So, and again, I preface a lot of these answers by saying this is my interpretation of the data, my experience, my practice, what I've, and so, and that's why there's lots of different people that have different thoughts on this. If you look at in the literature, I think it's perhaps unlikely if you have a headache type and pattern with a lot of sensitivity to light and noise. Typically, that's probably more likely to be a migraine or more primary headache pathology than directly related to the Chiari malformation. There are exceptions to every case, but I would be less enthusiastic about assigning Chiari as the culprit in that case.
This question was going to come up later, but it just came up in the chat, so I'm going to ask it now. It was actually unrelated to this, but it was like a second part of it. So concussion, I think I asked this last week. Do you see a high rate of patients coming in after concussion with Chiari? And then as a follow-up to that, what's your take on certain activity levels and different contact sports in Chiari patients?
Those are great questions. So this was the, a question that we had in one of my earlier studies that I did on Chiari, was asking the question, is it safe to do contact sports and play sports with Chiari? So we looked at over 500 patients playing sports over a period of years and surveyed them to understand what sports they were participating in, whether it was youth sports, middle school, high school, collegiate sports, and then asked them about their any injuries, or we looked at concussions as well. We also sort of had a comparison group of patients with arachnoid cysts as well, so sort of a different pathology, but so those are excellent questions. Of the 500 patients, there was one football player that had a quote-unquote stinger injury. So that's more of like a shooting pain down the arm that was probably unrelated to the Chiari. So our general conclusion was that and we included patients who had a diagnosis of Chiari without symptoms that we felt like were coming from the Chiari, or they had a treated Chiari. So these weren't that scenario where, let's say you've been diagnosed with a Chiari and you're awaiting surgery, or you're trying to hold off and see what happens with your headaches. These were patients that were either treated, or we did not feel like their symptoms were related to their headaches, for instance, were related to the Chiari. So in general, I'm very permissive in my patients playing contact sports. There are case reports in the literature of rare and scary things happening with spinal cord injury. So I do have that conversation with parents and families. But in general, there are a lot of kids playing contact sports, and probably a lot more with tonsil positions of different, different levels that just haven't even been imaged. So I'm generally fairly permissive. And I don't love football in general because I do see a lot of injuries. So super high impact sports like football, just from not having anything to do with Chiari, I don't, for my patients participating in football, I think there's a risk of injury just from the participation in football, but I'm generally fairly permissive. And so we did study that formally as well. The concussion question is definitely a very interesting one. So My thought is, yes, I do see initial presentations of Chiari after trauma when someone has a concussion. And the thought is similar to activity, as well as coughing and sneezing that can induce headaches. I think if you have a Chiari and then you have a concussion from either a sports related concussion, or you've been in a motor vehicle accident or fallen off of an ATV or out of a tree, patients can be more likely to have concussion symptoms from the same reason that I described earlier, in that they have reduced ability to move spinal fluid, across their skull base. So there is that thought as well. I mean, I think you probably hear a little bit of debate on whether or not that is possible, but in my experience, I have seen a fair number of patients present with Chiari after a concussion.
Mm-hmm. This is interesting. Would a connective tissue disorder, would it make it more likely to get a concussion or some sort of traumatic injury, even if it was a low trauma occurrence? So it wasn't necessarily like a huge car accident, but maybe there was a little fender bender. Could hypermobility or some connective tissues issues, I guess, can that cause some sort of like trauma?
Yeah.
Without, I don't know if you would even see it on a scan.
Right. So although I have an appreciation for and incorporate connective tissue disorders into my practice, that is not my specific area of expertise in connective tissue disorders. I know there are some individuals that really focus in on connective tissue disorders. So with my personal experience, I'm not really equipped to answer that specific question.
That's fair. I did want to, there was a question that came up I actually do want to ask really quick. Why do the tonsils like re-herniate? Why do they come back down after a decompression? And say it looks like the flow is totally normal. Maybe they've had like a cine MRI and they see the flow is moving pretty nicely. Why does that happen? And then is that something that you go back in and redo?
So after my practice is when taking the suboccipital, the bone in the back, I really limit the amount of bony opening. The cerebellum has the configuration to it where the tonsils really are only the bottom portion of it. But if you don't have if there's a large amount of bone that is missing, you can have more sort of what we call cerebellar sag, where the whole cerebellum just sits a little bit lower. So I wouldn't necessarily call it a re-herniation. It just may be more of a settling. So after even if you take a small amount of bone off and you get a post-op MRI at some point, maybe in a year, I don't typically do. So if there's a syrinx, I will get a follow-up MRI related to the syrinx, and then for patients without a syrinx, depending on their symptoms, I don't do a lot of post-operative imaging unless there's a specific clinical concern about it. I guess the scenario they're describing may result from just the cerebellum sort of sitting a little bit lower down, would be the most likely explanation.
If a reoperation is done, does the complication rate, does that go up at all, or?
Yeah, so anytime we do a reoperation, whatever the pathology is, whether it's Chiari or anytime you're going through scar tissue, if you look at different reports in the literature, the complications kind of go up just from dealing with scar tissue. So in short, yes. Is it significant? No, but yes, there can be. You're adding in another layer of with the scarring.
Yeah, and then that can cause different complications that even the second time around, the scarring at least.
I guess it's just more, potentially.
Right.
But I guess it's difficult to say.
Yeah.
I guess it would depend on why the reoperation is occurring. But if, in generally speaking, if you're having multiple surgeries, the idea of a complication can come up from just repeated operation, wound healing in general. just the, the more you go in through an incision.
Yeah, no. So earlier you had mentioned arachnoid cysts, and this was a question from earlier too that I wanted to bring up. I'm going to start with, can you define what they are?
Yeah.
Because I feel like a lot of people don't know what they are.
Yeah.
And then like what causes them and how are they treated?
Yeah, so I brought that up mostly just as a comparison, but similar to Chiari. So the probably the two most common things that I see, two of the most common things I see in clinic. One is Chiari, and then probably a close second is arachnoid cyst. And I group them together because they are frequently what we call incidental findings, meaning we can see them on the MRI, but they're not necessarily associated with symptoms. So an arachnoid cyst is a collection of spinal fluid that is within the arachnoid, and they can be in different locations. The most common location is sort of in the middle portion, sort of right behind the eye area within the brain, or within the head, I should say. And they can come in all shapes and sizes, and they typically do not need treatment. So unlike Chiari, where there are select patients where we know surgery can be very beneficial, surgery for arachnoid cyst is, we have a really high threshold prior to intervening, because the arachnoid cysts themselves, the fluid can occasionally accumulate or recur in a way that's unexpected, and so there's a high chance of needing a second procedure, and so we're very, very conservative there. Most arachnoid cysts do not need treatment. They're common, not quite as common as Chiari, but still very, very common in the pediatric population. And I think the key there is that they rarely need operative treatment.
So it's a really, really high threshold. What would that threshold be, I guess, that you would look for?
So typically the kids that end up needing treatment for arachnoid cysts are typically very young. So they may be born with an arachnoid cyst that is continuing to grow. So an arachnoid cyst that is growing, causing a shift of the brain and then an increase in head size, that would be a scenario where I think most would be in agreement with opening up the arachnoid cyst and allowing the communication. And most of those situations occur in kids under 2 or under 4 years old. But if you sort of make it past that age, it's fairly unlikely that you would need treatment for an arachnoid cyst. Again, exceptions to every case.
Right. So that was almost perfect for the next thing I really wanted to talk about, because it's kind of surprising that we don't talk about this a lot. And I know it's a big research interest of yours, so I wanted to bring it up. I thought you would be a good person to speak on it. But pediatric hydrocephalus, how is that usually diagnosed? Is that usually diagnosed quickly in kids? And what are some of like the presenting signs that make you order an MRI to even look for that?
So hydrocephalus is, from a surgical standpoint, the most common condition that most pediatric neurosurgeons treat as part of their practice. So hydrocephalus occurs when you have increased fluid, so more fluid, typically within the ventricles themselves. The ventricles are the fluid-filled spaces. And when the increased fluid causes clinical signs and symptoms, such as in a baby, for instance, a full fontanelle, an increasing head size that's crossing the growth curve and growing faster than it should, that's sort of a classic presentation of hydrocephalus. Hydrocephalus is usually it's usually caused by something. So the most common cause in the United States is from premature babies having bleeds into the ventricles and the surrounding brain. And so we already know that they're sort of at high risk for hydrocephalus, so they're being followed very closely. Hydrocephalus is also associated with spina bifida, or the specific myelomeningocele form of spina bifida. And then we can see what we call congenital hydrocephalus, where it's usually diagnosed in utero. So most hydrocephalus is sort of picked up in early on, or at least the majority of it is. And during that period of time, we usually have the ability to feel that soft spot and to measure the head growth. Hydrocephalus that occurs later on, for instance, related to a new diagnosis of a tumor, that is usually picked up on imaging. So any sort of the most common presentation for a child with hydrocephalus that's a little bit older would be sleepiness, lethargy, nausea, vomiting, headache. That would be the constellation of symptoms that we would see with hydrocephalus at an older age. Whereas if you're young and present with hydrocephalus, your head continues to grow.
Right. This is an interesting question. What is the difference between ventriculomegaly, so like a big ventricle, versus hydrocephalus? Is there even a difference clinically?
Yeah. So, and I mean, you could draw analogies from what you just mentioned to Chiari. So, at what point does a low tonsil position become a Chiari malformation? I mean, and this is getting into the semantics at all, or become a symptomatic Chiari malformation. So, and this is a question that we continue to study as pediatric neurosurgeons: is there a perfect ventricle size? Like, when do the ventricles become too big? Because there are plenty of patients I see that have big ventricles that their head size is great, they're otherwise clinically doing very well, and once you intervene or once you treat hydrocephalus, it can, similar to the arachnoid cyst scenario, if you place a shunt or treat hydrocephalus in someone that doesn't actually need treatment, that's there can be additional complications, and you don't want to treat patients that don't need treatment. So the question of when does ventriculomegaly become hydrocephalus is when we are assigning sort of clinical signs and symptoms, or there's some secondary effect. So if you have a kid that presents with large ventricles, there are other things that we do, like we'll get an eye exam in some cases, to look in the back of the eyes to determine if there's extra pressure transmitting along the optic nerves. We measure head size. Occasionally we'll do neuropsychometric testing to see where that child is in relation to their progression with learning. Occasionally we'll place a monitor. So it is a surgical procedure to place a pressure monitor to understand what the pressures are, and so we can investigate further. But it's usually the combination of having big ventricles and then other signs of increased pressure, whether that's clinical signs or symptoms or some documentation of increased pressure from an eye exam or from obtaining a pressure measurement. And so drawing a comparison to Chiari is sort of similar, where you can have an MRI image with tonsils that are low-lying, or tonsils that sort of meet this definition of 5 millimeters, but they're not always associated with symptoms, and they don't always need treatment. So it's really pairing the imaging finding of a low tonsil position with clinical signs and symptoms, whether that's a very large syrinx and scoliosis, classic headaches. Occasionally you can have swallowing difficulties, breathing difficulties with the low tonsil position that makes it sort of, in my mind, more of a quote unquote Chiari malformation rather than an asymptomatic low tonsil position.
So a question that came up which is actually really interesting. I'm going to further complicate is it hydrocephalus yet kind of question.
Yeah.
Say that there's also a Chiari. So in that situation with a patient, do you shunt them? Do you decompress them? Do you do both?
Very, very good question. I mean, these are very sort of interesting and complex patients. And we see them. They come up. A patient that presents with a real Chiari, big ventricles, and the question is the Chiari there? Is the tonsil position low because there's hydrocephalus and the fluid is pushing the Chiari down? Are they two separate pathologies, or are the ventricles big? Is there hydrocephalus because the Chiari is blocking the fluid flow such that it's sort of accumulating? So it's I will use as a tiebreaker eye exam, swallowing study, sleep study, to try to sort out, and occasionally you can actually see fluid sort of around the ventricles. So in short, I don't have a great answer for you. It's a really thinking about and studying the imaging, examining the patient, and trying to determine which do you think is, it's a chicken or egg phenomenon. What do you think sort of came first? And some patients ultimately end up needing both. So I've had patients where I'll treat the hydrocephalus, and I typically, in that situation, may think about something like an endoscopic third ventriculostomy rather than a shunt first. And I've had patients, get better with respect to some of their symptoms, but then end up having a Chiari decompression and then, get better. Had I done it in the opposite order, would the Chiari decompression alone relieved all their symptoms? I don't think we know in some of these patients, because you just have to make a decision at some point. But that's a very specific situation and just requires a lot of thought.
Yeah. So during, or I guess after surgery, what would cause arachnoiditis? How worried are you generally about that happening? And then is there anything that has to be done when you find it, that you have to treat it maybe surgically or not?
So we're learning a lot more about the arachnoid in general. It's interesting. There's a lot more interest in spinal fluid flow, through organizations like this, and then just more broadly than there was before, and specific to arachnoid itself, and understanding how it responds to surgery. So there are some, so arachnoiditis can occur anytime, you're manipulating the arachnoid. So there are some patients who, and not all surgeons do this, but there's select patients, for instance, those patients that might have big ventricles and that I'm concerned might have subclinical hydrocephalus. When you do, let's say you're doing a duroplasty, some advocate for always opening the arachnoid, checking the obex, making sure there's no web. Some in select patients, in some select patients, I'll leave the arachnoid intact because there's a whole network of CSF that lies beneath the arachnoid. And so when you open the dura, there's not, all the CSF doesn't sort of come out. When you open the arachnoid, there's a lot more CSF that comes out. So trying to reduce the intra-arachnoidal dissection, I think, can be helpful, although I'm not sure it's been studied in large scale in that way. So if you don't do a duroplasty, you're not really going to have arachnoiditis. And then if you do a duroplasty and don't open the arachnoid, I think there's less of a chance of having arachnoiditis. Of course, if you get an infection in the spinal fluid, there's a higher chance of having arachnoiditis. And then, there's a possibility of the patients more just having in sort of irritation postoperatively. In terms of having sort of imaging evidence of arachnoiditis on an MRI that's significant enough to cause like fluid loculation. It would be, I think, a combination of symptoms and then seeing some evidence of it on the imaging. Maybe failure for a syrinx to resolve, clinical symptoms. And if someone had an infection, that would, in that scenario, that would raise my suspicion.
Okay. So I want to talk a little bit about syrinx for a second. Other doctors who have done this Q&A with us have been talking a little bit about surgery that's usually done to prevent injury to the cord and to the nerves. I think you've studied this a little bit, but is there any way to tell if there's injury to the spinal cord at all? Like, can you tell that, or
Yeah, I get this question a lot for both Chiari and then for things like spina bifida and tethered cord. And, now that we're doing intrauterine surgery for myelomeningocele, there's a lot of questions about, the how does the tissue look? How can you assess for damage? It is, so you can see changes with the brain, spinal cord on MRI pretty well. And in certain things like, brain tumors or other pathologies, it's common to actually see it during the surgery in terms of quote unquote damage. For Chiari, you'll occasionally see that the tonsils can look a little bit compressed, but they typically don't, I wouldn't say they look damaged. It's not, I don't really see a lot of, again, damage of the tonsils themselves, similar to the spinal cord itself. So that's not something that we typically see from a visual naked eye standpoint in the operating room.
Do you see anything, or can you somehow, with some kind of biomarker or something, measure that for syringomyelia though? I know that's a big concern, is if that is left to get bigger or to just get worse, you might get damage to the nerves there.
Yeah, so that's a very good question. So that's the main reason why I think at the beginning of the session I mentioned that that syrinx, an expansile syrinx, is probably the most agreed upon indication for Chiari surgery amongst pediatric neurosurgeons, a really true expansile syrinx, because what can happen, and we do see patients with this, a patient that presents with a syrinx and let's say arm pain or numbness, what happens is that the syrinx at some point can actually rupture out through the back of the spinal cord, and it can rupture out through that the sensory fibers run along the back of the spinal cord, and so you can get numbness related to that. So we don't want that to happen, and what I wanted to mention is you can see in a case with a really expansile syrinx, well, you can't necessarily determine if there's been damage. You can tell if the cord itself is expanded or if it, has fluid in it. But it would be difficult from a visual perspective to say that the fibers themselves have or have not been damaged. That the damage, I would say, is best determined by physical exam, probably, and how their physical exam is, and then in combination with the MRI.
Right. Okay. I had a question. Okay, so say a child gets a shunt for their syrinx. How likely is it that when they are older, they're going to need that shunt either redone or what? Because obviously that child's going to grow. Is that something that becomes a problem over time that maybe someone will have to revisit? And at that point, is that something that a pediatric neurosurgeon would do? And we kind of talked about this with Dr. Rock last time. How does that transfer of care work from kid to adult?
Well, I know, are you talking about Brandon Rock?
Yeah.
Yeah. So I know they're very, he's written, I think, articles on just continuity of care. And so I think each practice is different. Each surgeon is different. We see patients in our clinic, up until their mid-20s. And then I also see adult patients with tethered cord, for instance. So it's not like there's all of a sudden a sort of lapse of care or non-transition of care. But that is an important point. Some practices sort of different ends of the spectrum in terms of the age to which they follow patients. So you mentioned, to clarify, your question was in reference to a syrinx shunt?
Yes.
So it is not very common to actually have a syrinx shunt. So when you have a syrinx, I think the first, second, and third goals are to address the cause of the syrinx. Most of the time that would be, it's usually related to either a Chiari or other common pathologies associated with syrinxes are infection, tumor, tethered cord. You can see what we call sort of an idiopathic syrinx, not associated with anything else. But in related to Chiari, the goal would be to reestablish that spinal fluid flow. It can be difficult sometimes, and so there are select patients that ultimately will have a syrinx shunt placed. The shunt can either be, so you asked about growing. Some syrinx shunts are placed from the syrinx itself into the subarachnoid space. So it's a piece of tubing that called sort of K tubing, where there's two limbs that go into the syrinx itself, and then it drains into the fluid around the cord. So for that, the patient can grow with that, and it's not going to, present any difficulties. The second type, or that, and then another common type of shunt would be syrinx to syringopleural shunt, so into the space around the lungs, or you can have a syrinx to peritoneal shunt, which is the abdomen area. So in general, when we place, so ventricular shunts are much, much more common than syrinx shunts. And when we place ventricular shunts, we rarely have to resize tubing as a patient grows. The tubing that is placed into the abdomen or the pleural space there's usually extra tubing. So I think it would be unlikely that the shunt would need to be sort of electively revised or revised just due to the patient growing. Syrinx shunts can stop working over time, and so they may need to be revised like other shunts, but the number of patients with syrinx shunts is pretty small, at least in our practice. I see very few patients that ultimately end up needing a syrinx shunt, as we're able to address their primary pathology causing the syrinx. Okay. Sort of a last resort for a syrinx in most patients.
Right. So this is going to be the last call for questions because I want to try and get these questions in. But this is interesting. So you mentioned that you do see adults that have tethered cord, and then there's growing discussion about tethered cord syndrome, and maybe where you don't necessarily see it literally tethered down at the bottom, but maybe there's some like weird phylum, or some like the conus is at a normal level, so the end of the spinal cord is in a normal space. What do you usually do? You have a particular threshold where you would say this patient might need surgery and this one may not?
Yeah. So are you referring to occult tethered cord?
Yeah.
Yeah. So there's different. I mean, some use the term occult tethered cord to mean anything other than an open myelomeningocele. So spina bifida is a big term that means a lot of different things. On one end of the spectrum, you can have a small cleft in the bone, which is called spina bifida occulta. On the other end of the spectrum, you can have an open myelomeningocele, which is associated with hydrocephalus, a Chiari 2 malformation, which is different from Chiari 1 malformation, syrinx, scoliosis, tethered cord. So that's one end of the spectrum. So occult tethered cord, the way that you're using it, I think you mean to say that the position of the spinal cord is in a normal position, and then the phylum, which is the ligament that connects the end of the spinal cord to the end of the spinal canal. So the spinal cord ends, quite a bit above the end of the spinal canal, which is in the lower back. That phylum can be thickened or it can have fat in it, and in some cases can cause tethering. This is another area where there's a wide range of thoughts and opinions on whether or not a child with a spinal cord that ends at a normal location and a phylum, let's say, that does not have any fat in it. Some feel like that scenario can cause symptoms, and others, their assessment is that it cannot. Again, I don't think everything is not black and white, and so there are exceptions. My general practice is I think it would be highly unlikely that a completely normal image would actually be representing tethered cord syndrome with no other abnormality on the imaging. There are patients who have a similar picture, but let's say a syrinx in the distal spinal cord or some other imaging finding that might tip us off to, and combined with very clear symptoms that we think are referable to tethered cord. So, if you have a low-lying conus and fat in the phylum, I think that's one scenario, and the appropriate symptoms, I may recommend tethered cord surgery in that case. In a setting of a normal position conus, I am really, really, really careful to fully understand what's going on, and it would be a rare scenario that I would recommend surgery in that case.
Yeah. So essentially, go ahead.
But you will find individuals who may be more willing to give a diagnosis of tethered cord syndrome with completely normal imaging, but that's not something that I typically do.
Yeah, this is a good question. What is a low conus? So, and I guess it's different in kids versus adults. So
yeah. So in general, my sort of threshold for the lower end of normal is about L3. So anywhere L3 and below with symptoms, especially with a fatty phylum, then I'm sort of placing that patient in the more abnormal category with respect to imaging. L4, 5 is I think agreed upon as low. L3 is probably a transitional region where can be normal. could be abnormal. And then L1 and 2 I consider normal. So yeah, normal range anywhere down to about L2, 3. L3 is probably at plus minus.
Right.
And then
That's your
L4.
bell curve.
Yeah.
Okay, and then this is interesting too, and I guess this is going to be related to specifically like tethered cords. So we're talking about like on your MRI tethered cords and images. What's the rate of retethering after a detethering surgery?
Yeah.
Because this is a really good point. Every neurosurgeon says something different, and I have a feeling you're going to say something different to what everyone else has told this person. But go ahead.
So I heard your question, that I'm also seeing that's specific to a tighter fatty phylum. So the rate of retethering, I think, is specific to the pathology to begin with. So a lipomyelomeniingocele, which is a specific type of spina bifida where there's fat coursing through the nerve roots, the rate of retethering after that procedure can be high, like very high. So that is it's a completely different scenario than what I'm seeing here, a tighter fatty phylum. So the rate of retethering after that procedure is low because you're not, the pathology is being taken away. So for instance, things like myelomeningocele and lipomyelomeniingocele, the cord is still low lying. So anytime we do an untethering, it's not that the spinal cord suddenly sort of springs back into place. When you have a situation where there's thought to be tethering from the ligament, a single ligament, either being tight or having a little bit of fat in it, when you cut that, it already, during surgery, it will sort of, that ligament itself will move up, and there's usually quite a bit of space between those two ends. Sometimes we'll even take out a piece of the ligament so that there's, the two ends are not even touching. So I would be very hesitant to assign a diagnosis of retethering or reoperate after an untethering for a fatty phylum or a tight phylum. If there was tethering, I would be suspicious that perhaps that there's arachnoid scar. And so when you get into, we talked a little bit about arachnoiditis before, there are some kids that can present with arachnoid webs in the spinal canal that with fluid accumulation. And sometimes those kids have a difficult time because even if you do operate, the process by which their body formed the arachnoid to begin with just happens again after the second surgery. So going in and doing more surgery is usually not the answer. So I think for that specific indication, a tighter fatty phylum, I would not recommend. I think it's unlikely that there would be retethering, and I would not usually recommend surgery for that.
So in a case like that, would you maybe refer that patient to, would they stay with you in your care, or would they wind up at like a neurologist or a pain management specialist, I guess?
Yeah, so I typically involve, my colleagues in different disciplines closely in all my patients' care, preoperatively as well as postoperatively. So most of my patients, anytime I do surgery, I'm still going to be following them for, it's not oh, this didn't help, or you have symptoms, see you later. So I'm following with them. And so, my treatment plan for patients is we're gonna figure out a plan and treat their problem. If it involves surgery, great. If it doesn't, that's fine. So surgery is just one tool that I have to help treat the patient. So in a situation like that, we're frequently involving urology, neurology, physical medicine, rehabilitation, sometimes the pain clinic, depending on what specific, sometimes GI, depending on the specific symptoms at hand.
Okay. And I guess just to round it out at that point, say you did a surgery in a kid who maybe had Chiari and syringomyelia, and there are persistent symptoms that maybe the syrinx is gone, but there's still some pain issues, maybe even like headache. What do you recommend as you follow that child going forward, and how do you incorporate the other members of your team to make sure that those symptoms are managed long term?
So the scenario you gave with syringomyelia, typically, so patients that present with syringomyelia don't always have a ton of headaches. So I guess if the so it's very individualized and very specific. So it's hard for me to give a specific general scenario. And a lot of these answers I'm giving today are just more general. And I'd like to, as a disclaimer, there's, different scenarios with different specifics. So these are just sort of, general answers as to the these different, clinical cases that you're presenting here. So in someone that was treated for a syrinx, if I see really great resolution of the syrinx, I'm going to be pretty hesitant to do any more surgery in that case. Right. And so let's say the patient is having headaches. My thought is, well, we've established enough spinal fluid flow such that the syrinx has gotten better. I think it's unlikely that there's somehow enough fluid sort of moving such that the syrinx is better, but that it's still causing headaches. So we would involve neurology, and then sometimes our pain management team here, which I think at a lot of places is it's really evolving. So pain management now is a very multidisciplinary process, and so I think some parents and families hear pain management and think that it's more of a band-aid where we're just going to mask the pain and it's all about medications, and that's not really what it is. It's a really multi-modality, multidisciplinary approach where there's physical therapy, occasionally there's injections, there is psychology, psychiatry, there's patients come and they meet with a lot of different team members and sort of approach the pain from a lot of different perspectives. So for my patients that come and they say, oh, I've had pain for years, and then we start with common things being common, try to address what we can that we think might be causing it. But if sometimes kids that have had pain for so long benefit from that multidisciplinary approach to really tackle their pain, whether it's from headaches, neck pain, back pain.
Yeah, and that kind of almost circles back to the question I asked before about the holistic stuff. So is that something that's incorporated into the pain management?
Yes. Okay. So pain management, and then there's something that called osteopathy. So there's osteopathic manipulative medicine where a lot that works really well for a lot of patients. There are different regions of the country have different numbers of practitioners that are practicing in OMM, but that's another modality that works really well, and our PM and our team here has that as well. So I think when it comes to pain, if you rule out any rare, scary things causing the pain, and it's I think that's good. Then let's say you don't need surgery. That's really it is a good thing. I know sometimes I get a lot of families that come and what I hear most from families is they want answers. Their child has been in pain, whether it's headaches or whatever symptoms they've had, and they get an MRI and they have this diagnosis. And so I there's a lot of hope and enthusiasm for the Chiari sort of being the source of all the symptoms, and more often than not, it's there's usually other things going on, and so it can be disappointing for some patients to hear that a surgery is not going to fix all their problems. So I spend a lot of time connecting them with other individuals that are able to, as different specialties, we're all going to work together and figure out a plan. So I try to communicate, hope, and that it's sometimes a process, and it's usually not one simple fix. It's usually sort of small changes over time. It's rare that someone has an aha, this is, and sometimes it's the Chiari. Sometimes the Chiari is that solution, but a lot of times it's not. And so Chiari can be a frustrating process. And I see a lot of patients go through that. But I think, as you mentioned, I'm a big proponent of those alternative therapies because I think that they are, we call them alternative therapies just because they weren't, developed within the Western medicine umbrella, but they are equally as important, I think.
Yeah. Do you have any advice maybe for like parents about how to advocate for their child? Maybe if they're in that kind of position, like what are some of the steps that they can take to make sure that they're getting these alternative therapies, seeing you going around to the different specialists who they need to see? What steps do they need to take to make sure that their child is taken care of?
Well, I think with in terms of like having an imaging diagnosis of Chiari malformation.
Right. Yeah.
Yeah. So I think starting with a neurosurgeon is great because they're going to be the ones that can tell you, I think your child needs surgery. I don't think your child needs surgery, or we're not sure yet. We need more studies. So I would start there. Some neurologists are seeing a lot of patients with Chiari too. So there are some neurologists that are that see a lot of Chiari patients as well. So as long as you get into the hands of someone that sees a lot of patients with Chiari, to then understand, okay, do I need surgery? Do I not? What other testing do I need? If you get a recommendation that it's unlikely that your child needs surgery, then you have to look at what symptoms you're having. Some of those alternative therapies are not always covered by insurance, so some patients are limited in that way. But a lot of hospitals and clinics are incorporating them. So sometimes it does take a little bit of legwork on your end and working with your neurosurgeon and your pediatrician to understand who in your area. So I have a lot of patients that come see me from many hours away. So my local contacts here are not going to be great for someone that lives 6 hours from here. So we usually work in conjunction with their local pediatrician who may be more familiar with specific pain management or physical therapy, for instance, practitioners in their local area, because it is a process, and so it's a lot on families and taxing to have to drive, so far for instance, physical therapy appointments. So we try to work in conjunction with what's covered by insurance, what's close to home, what symptoms you're having. So I don't have one specific, one specific action plan. I do tell parents to, it's sometimes a stepwise process, and so I sometimes hear the journey can be frustrating when let's say you've tried physical therapy and then you want to go on to the next step, let's say booking an appointment with pain medicine. Some advice that I give is to maybe book those appointments ahead of time so you have them there, so you can always cancel them, and that way you're not left with, okay, now I book out appointment 3 months, and then waiting another 3 months in between. So thinking ahead for the next step. Okay, well, if this doesn't work, neurology, our neurologists are excellent, and similar to neurosurgery, sometimes different services, I don't mean to single out neurology, but whatever specialty it is, there can be different, wait times and clinic times getting in to see that specialist. So getting those appointments on the books ahead of time, and then you have that as an option. And if things are going great, then then you can cancel. Sort of depends on where patients are. Some patients come with, several years of going through this, and then other patients, it's a different scenario. So again, sort of coming back to the individualized approach.
Yeah. Okay. I'm so sorry. 2 more questions, and then that's it. This is kind of related to that, though. How would these patients find a neurologist specifically? So I know you were kind of alluding to the surgeons really know this the best because they see it the most often. But are there neurologists with whom like the surgeons work that maybe that would be a good place to start, or how do they find those specialists?
That's a good question. I think it's different in every region and every hospital. So I don't have a great answer for that, other than potentially reaching out to the pediatricians. Sometimes know, but not always. So I think going to a neurosurgeon is probably the best place to start, but I didn't want to discount a neurologist that may have expertise in Chiari. So I do know some places where there happens to be a neurologist that really sees a ton of patients with Chiari, and if your hospital, if your clinic has that individual and as an option, I think that would be helpful as well. But I think for the most part, starting with a pediatric neurosurgeon probably makes the most sense, because that individual can then advise on, whether or not he or she thinks you will need surgery and what other tests you may need.
Yeah. And then my last question is, kind of just specific to your practice, so we could just talk about that. Are you I know I'm not doing a good job of asking this. I know the regulations have been kind of like relaxed right now because of the pandemic. Are you seeing patients by telemedicine, and can you maybe get second opinions for people who might not live local?
So that's a very good question. Currently, and these things are the regulations and rules are changing constantly. So what I say today may not be true several months from now. Currently, within the United States, in order to give a formal second opinion where you're giving, patient medical advice, you need to have a license in that state. So as I work in Missouri currently, so from a virtual aspect on Zoom, I can see patients in Missouri. I trained in Michigan, so I have a Michigan license. So Michigan, Missouri, and then Illinois, because we're right next to Illinois, we have that same ability there. So right now, based on current national regulations, as a practicing physician, you need to have a license in that state. There are several second opinion programs, I think nationally, that there's some loopholes, and it's I don't know all the exact details regarding that. It's not the same as a typical Zoom visit in all cases, so I can't speak to that. That's a program that's currently in development, but if you're talking about a standard Zoom second opinion, the practicing physician needs to have a license in that state according to the current national guidelines.
Right.
As my understanding of them and what I've been told by our institution.
That's usually who you have to go to. So that's
right.
Good.
Okay. So that what I mentioned was coming from the recommendations from our institution.
Right.
If you are physically present, then we have patients come, you can come from anywhere, but that the virtual limitation does require the physician to have a license in that state.
Yeah. That was an excellent response. Thank you. All right, so I want to thank Dr. Strahle for being with us. I'm pronouncing it correctly, right? Because I did this.
Strahle.
Okay, cool.
Yeah.
Thanks for being with us. I'm sorry this went super long. You had a lot of really interesting questions. I'm sorry.
Yeah. This was great. This was a lot of fun. I'm happy to, speak anytime. If people have questions, please feel free to reach out to me, via email, or if you have any other questions, I'd be happy to answer them.
Thank you. Thanks, everyone. Thanks for coming.
Okay. Thank you, Dr. Strahle. Thank you.
Okay, bye. Thanks, everyone, for coming. Bye.